Um, Kim, do you mind introducing yourself and telling us a little bit about what you do?
Sure. I am a nurse also. My background is in high risk OB, which is how I had the honor of meeting Becky, and we worked together for a while. Um, I am a nationally board certified. I just passed my board exam in January, I found out. And so nationally board exam qualified health and wellness coach. I've been coaching for the last several years with a primary focus on Whole30, but have now expanded that to be more of an integrative and holistic health coach and working kind of with metabolic disorders.
Thank you. So, hi, Becky.
Hello. Hi, everyone. I'm Becky,
So,
and I
yeah,
guess I should keep my camera on this for this call. I usually like to put it off, turn it off, but since I'm presenting, I should leave it on. But yeah, I'm a nurse practitioner, specializing with high risk pregnancies and also some hormone balancing. I've been doing that for a long time. So I work with Kim and I work with Tanya, work for Tanya. And yeah, it's pretty great. I have a pretty great work life. I get to do a lot of different things. So I'm still in the hospital and then doing this more functional medicine, natural approach to medicine. So I really have one foot in both camps and I kind of like to live there. I have a lot of compassion for my physician and nurse practitioner colleagues that don't know what we weren't taught in medical school and nursing school, about more functional strategies of health. And yeah, it's pretty fun to help really smart people just live
great.
better.
So Becky, yeah, is with the high risk OB group in town called obstetrics, and they take care of all the quintuplets and quadruplets and moms having challenging pregnancies and things like that. And Becky's been doing it for decades now, even though she only looks 15. And so Becky and I went to our initial kind of hormone care training probably 10 or 12 years ago now, I
Yeah.
think at this point. So we've been working together for a long time, but Becky's also at this point working on an applied functional medicine certification, which has just been really great for our practice. But so I think we've all in our practice anyway, and I think people are seeing it everywhere. There's a lot of discussion about weight loss and semaglutide and this magic drug, and I think people have a lot of questions about it. And so Becky's going to talk to us obviously today about that. But I think there are a lot of health benefits, which I think the problem with a lot of medications is that they tend to either block receptors or poison enzymes. Like that's a David Bronstein kind of quip. But that's kind of how a lot of medications work. And we can all imagine if you're doing something like that long term in the body, where you're blocking receptors that are there for a reason and poisoning enzymes that are there for a reason, that leads to all kinds of downstream health problems. But one of the things that's been pretty, I think, amazing and surprising with this whole family of medications called semaglutides and similar medications is that they're peptides, which are signaling hormones. So they're not even necessarily medicines, synthesized artificial medications, as much as signaling hormones that are replacing things that our bodies are lacking. And because of that, it turns out that there are a lot of side benefits as opposed to side effects. So it's pretty interesting stuff. And Becky will talk about this, but we've been seeing some really nice success in our practice with it. So thanks for putting this together for us, Becky.
You're welcome. Okay. So please, if you have questions along the way, just holler. it can be very collaborative. And I have Tanya here, who's actually one of my semaglutide patients for some testimonial work. So if you bear with me, I will share my screen. Can you guys see that? Okay. All right. So the name of the presentation is called Semaglutide. Is it a game changer for weight loss? And I would say, yeah, it is if you do it right. And that's really key, because there's a lot of practices around that are not doing it right, and patients are having really terrible side effects. And so that's one of the things we manage well. I feel like our dosing strategy is such that we are able to minimize side effects and maximize weight loss. Okay, an overview. So semaglutide is FDA approved for weight management. They're the commercial medications that you may have heard of: Ozempic, Wegovy, Mounjaro, and then there's a compounded medication. That's what we use in our office, the compounded semaglutide, which gives us a lot more opportunity for, dosing adjustments and very minor dosing adjustments. When you use the commercial products, you're kind of stuck at the doses that are available. And so they can't customize it, because they come in these like pre-filled pens, and you don't have the same just ability to be flexible on dosing. You can't adjust a little bit. All right, how does it work? So it is a GLP-1 receptor agonist. So it mimics the natural incretin hormone GLP-1, and that just tells our brains that we're full. Okay, so that's a hormone we have, and the semaglutide just supports that natural hormone. It regulates appetite and energy balance, and really is fantastic for people who struggle with cravings. It slows gastric emptying, so your stomach holds on to food longer, you feel full. And it just promotes satiety and reduces your food intake. So if you feel full faster, you should eat less, unless you really like it and you overeat. But you're not going to feel good if you overeat when you're on semaglutide. Okay, here's a little bit about the science on how it works. So actually, this picture came from a study where they were trying to prove that semaglutide would help people with fatty liver. So fatty liver is a glucose problem, because the glucose in the liver turns to fat and weight gain. And so this study was done for people who already had a diagnosis of fatty liver, and it just showed that it could really help those people. This study is very recent. It was in 2023, the end of last year, it came out. So we see fatty liver in this office every week. People come in, they get their labs done, and lo and behold, their liver enzymes are just a little bit off. And they may not have a diagnosis of fatty liver, but they're leaning in that direction. And that's a glucose problem. Lowering insulin levels is key. So the insulin resistance is a big problem, because elevated insulin levels can promote fat storage and inhibit fat breakdown. And all these things happen when you have high insulin levels: inflammation, heart disease, constipation, hypertension, elevated triglycerides. And that's when menopausal women in particular, everyone complains about their belly fat, like they're gaining belly fat. And as your hormones get depleted, you are more prone to insulin resistance. And then you kind of can pack on the pounds if you're not careful. Okay. When we're talking about losing weight, you really, really want to lose fat and maintain muscle. The goal is to lose 1 to 2 pounds a week. If you lose weight faster than that, it's very likely you're losing muscle and you should slow down. And so have you guys heard the term like Ozempic face or Ozempic butt? I don't know. But it's for people who lose weight really fast and they also lose muscle. And so we are extremely careful about that in our office because it's hard to put muscle back on once you lose it. You have to be very intentional about it. So we use this in-body scale that measures the fat and muscle in your extremities and in your trunk. And when patients come into the office every week for their injection, we have them get on the scale. And we can see if they're losing muscle. And if they are, we may make a dose adjustment. And if their total body weight is the same, but they've gained muscle and lost fat, that's awesome. They lost fat, maintained muscle. So their total weight may not have shifted as much as they want, but it can really identify that their body composition is shifting, which is way more important than the actual number of our total weight. We do ask patients at their consultation, like, what's an ideal weight for you? Like, where do you feel the best? What's sustainable? And then we have them get on the scale and we see if that matches with what InBody thinks is ideal. Because we also want a realistic goal, right? So we do have a kind of goal weight in mind, but we're also looking at visceral fat. This scale measures visceral fat, which is a fat around your internal organs. And that fat is the fat that is the most concerning for cardiovascular disease and overall health. So what I tell patients is don't look at the total, like how much you weigh. Let's look at the visceral fat if you really want to see if you're doing a good job. Okay. We also don't want to forget about hormone balance and thyroid optimization. It's so important to look at both of these, all these numbers. So for women, very important to balance estrogen, testosterone, progesterone. For men, very important for good testosterone levels. Thyroid, super important. As women get older and get closer to menopause, our thyroids get a little bit lazy. And a lot of patients will say, oh, I had my thyroid tested with my primary and they said it was normal. Well, normal is like this big, giant range, right? So it doesn't mean optimal. So I would like, when we're looking at numbers, and we do a lot of symptom evaluation. And like I had a patient today even, so I put her on a very, very low dose of thyroid medication. Like I called it a baby dose. And she came back today, 6 weeks later. She has no more constipation. She's not losing her hair. She lost a couple pounds. And that's all we did was manage her thyroid. And she's 50. And so, but her other like her previous labs, previously to me starting the medication, weren't abnormal. They were just suboptimal. Like they wouldn't flag on a normal lab report, but they flagged for us because we're looking at a tighter range of numbers. And I love doing like good testosterone balancing with semaglutide because that also helps our patients maintain muscle. Super important. Okay, there's a bunch of clinical trials with semaglutide, and I actually researched all the different commercial medications and kind of how they were developed, and it's pretty impressive. They had people with like stage 3 renal disease, so their kidneys were shutting down, and they responded well to semaglutide. The cardiology literature, there's some good data about semaglutide improving lipid panels. And I actually had a patient a couple weeks ago. She was so excited. She did a 12-week program of semaglutide, and she came in and she had just done her cholesterol panel with her primary care. And I had her send me a screenshot of her labs because they were so impressive. So her total cholesterol dropped from 250 to 140 something. Her LDL, which is the L for lousy is what I call it, dropped from over 100 to the 50s. Her HDL, the good cholesterol, went up, which is good. And her triglycerides went down significantly. And her primary care said, well, what are you doing? Like, I don't have you on a statin. I don't have you on cholesterol lowering medication. And she's like, I'm just doing semaglutide. So it was pretty impressive. I mean, I saw the data in the journals, and then I had a real patient with the same data. That was pretty fun. Okay, the safety profile. There are some side effects that you have to manage, and we can do that well with dosing. Okay, so the most common side effect is nausea. So we have compounded semaglutide with vitamin B6, and that combats nausea very well. We actually use B6 in pregnancy for morning sickness. It's a good one. Constipation is considered a serious side effect. You do not want to get constipated on semaglutide. If you get constipated, you're not going to lose weight and you're going to be miserable. And we had a patient who came in for some hormone pellets, and she was an ER nurse. And she told us that in the last 6 months, they've had patients in the ER with like severe constipation from being overdosed on semaglutide. So that's a bad one. And we have a whole protocol to prevent constipation. So if you lean in that direction, it's probably better to be cautious with the dosing. The diarrhea, that usually happens because people overtreat for the constipation and they kind of lean the other way. So Tanya, can you speak to kind of your experience with a little bit of nausea and how you felt? Oh, you're on mute.
Okay, so first of all, if any of you have seen me, you would probably wonder why I'm on a weight loss program with semaglutide. So first of all, I'm 61, and I've been trying to lose 5 or 10 pounds for 45 years. You know, just want a couple of pounds off, you know. And then as I got older, I gained 10 pounds and I couldn't get my rings on. And, but, you know, that's one thing. The weight is one thing. I'm not obese, but my insulin resistance was going up, which, you know, Becky mentioned. So I'm like a skinny fat, or I'm a skinny pre-diabetic, and wearing a continuous glucose monitor, checking my labs, my fasting glucose is up. And they tell you numbers like, if you're fasting glucose, for every point above 84, it increases your risk of diabetes by 6% in 10 years. And so, you know, your primary care doctor might say, oh, it's under 100, oh, it's under 90, it's great. But, you know, being above 84 is already kind of a marker that you're pre-diabetic and your insulin levels going up. So that's really my biggest concern. And it's great that I've lost some weight. But to speak to Becky's question about the nausea, I think it would probably be worse if we didn't have the compounded B6 in with the semaglutide that we're using. And I do a little bit of Zofran, which is an anti-nausea medication. But I'm on a really tiny dose. So if you look at diabetic dosing, it's 100 milligrams, right? The Ozempic pen and with those patients, I don't know how they do it, because 100 milligrams is a lot. And we start with 10, and then I'm at 15. So, and I'm losing weight. So as Becky mentioned, you know, it's a very personalized dosing regimen. We just see how people are feeling. You know, if you're constipated, if you have nausea, then, you know, we're not going to bump up your dose until your body kind of gets used to it. And you usually start feeling better with it. But some people don't need much at all, just basically a whiff to get some of the health benefits from it.
It's so true. So in medicine, we often use the term minimum effective dose. So that is really true with semaglutide. We just try to get to there's like kind of a dose in the middle of our whole dosing structure where people usually settle in. And if they're losing 1 or 2 pounds a week, then we kind of stay there. It helps the pancreas. It supports, of course, the liver. Yeah, and I've been very impressed with the lipid stuff that I've been seeing, like in real life now too. So as far as serious side effects, if patients have any kind of gallbladder disease and they're at risk for also getting pancreatitis, and that's a deal breaker. If you have a history of pancreatitis, you probably won't tolerate semaglutide very well. So part of our intake every week, we ask patients, are you having abdominal pain? Are you having any issues, where that pancreatitis is very painful. So you don't want that. And then you cannot do semaglutide if you have a personal or family history of medullary thyroid cancer or multiple endocrine neoplasia syndrome type 2. So that thyroid cancer is actually not the most common thyroid cancer. I think papillary thyroid cancer is the most common. So I do have patients that have had a family history of papillary thyroid cancer that actually got semaglutide in a different place, a different office, and they did well. If you have pancreatitis or gallbladder disease, that's a deal breaker. Type 1 diabetes is not, you can't take this medication either. Okay. Type 2 diabetes, yes. It's a totally different it's a totally different disease, even though it has the same name. Type 1 and type 2 diabetes. Type 1 is an autoimmune disease, and type 2 is more like an insulin resistance lifestyle kind of a disease. Not improved for pregnancy or breastfeeding or for children at this point. Ideal.
One thing I wanted to mention that Becky's pointed out as well with the men type 2 or the and the thyroid, and the thyroid cancer, that was only found in rats actually, but I think they're taking a lot of precautions behind that. So the studies that was an issue is actually in rats and not even humans, but I think they're just taking the road of caution. So
and these are rats that got super high doses of semaglutide also, and some of them developed thyroid tumors on super high doses. So it doesn't really translate the same, but like Tanya said, just being cautious. All right, ideal candidate are people whose BMI is over 30, if they have pre-diabetes or lab markers of insulin resistance, any kind of comorbidities, high cholesterol, hypertension, people who struggle with cravings and therefore overeat, and those who've tried to lose weight otherwise, and failed. Like Tanya said, she's been trying to lose 10 pounds for 40 years, which, initially, like when Tanya wanted to do the semaglutide, I kind of laughed at her a little bit because I'm like, oh, you want to lose 8 pounds? Okay. But then like when I really looked at her labs and realized that she's a great candidate for this, and we can reverse this pre-diabetes that is developing. And also like Tanya, like many of us, has times where she craves things. And I know for me, Tanya, both, it's more in the evenings, like definitely get hungrier then. And so it's really good for people who struggle with cravings. Even alcohol or nicotine, it can help with that. People will say, they used to enjoy a nightly glass of wine, but now they don't want it. Like they don't even want it, which is really good. Okay, we do a full panel of labs before every patient starts semaglutide. So we check all the hormones, liver function, kidney function, all the thyroid labs. Like a lot of primary care docs will just check a single thyroid lab, and that's where they'll say, you're normal, you're fine. But we do the whole panel to check all the different thyroid markers that are super important. We check inflammation markers. We check some vitamin markers, vitamin D, B12. We do a full chemistry panel, electrolyte complete blood count, which is red cells, white cells, platelets. We do a hemoglobin A1C, which is a 3-month average of your glucose, and also a fasting insulin, because insulin resistance is very common in obesity. Dosing strategies. So we have basically a 12-week program. So we start at this low dose and go up very incrementally each week. Unless we find a dose that's really working well, we stay there. So every week we talk to patients, ask about side effects, see their weight loss, and what I like about the InBody scale too is someone can lose like 0.8 pounds. Like you would hardly see that on a regular scale, right? But it goes to like the 100th of a pound on this InBody scale. And I'm like, so patients are like, oh man, I only lost this. I'm like, yeah, but look at your muscle, look at your body fat percentage. And you did lose weight. So it's good. So I mentioned minimum effective dose. And what we're finding is sometimes like increasing the dose isn't better. So a lot of us think that, right? With a lot of things, like more is better. If I do a little is good, more is better. And that is not true with semaglutide. And actually, I talked to one of the other nurse practitioners in our office. She had a patient this last week who is on tirzepatide, which is a similar medication. It has a little different action, dual action, but she started off really low too, just like Tanya, and went up from 5 to 10, stayed there for a little bit, went up to 15, and that was too much. Like she said, she had side effects, she didn't lose any more weight, so she went back down to 10. So that's like more is not better. And the whole goal is to get you off of this medication. Like we don't want patients on this long-term necessarily. Some patients can do a single 12-week course and be done, lose 10, 20 pounds, and they're done. Some patients do a second round because they need to lose more weight. But we don't want patients on this for 2 years. And I think that's the difference with the commercial stuff is a lot of those are recommended to be on for long term. Because if you come off and if you change nothing while you're on the medication, don't change any of your eating habits or exercise habits, you are going to gain the weight back. So we still have to do all those things to lose weight, but the semaglutide makes it easier to do those things because you're not as hungry, you feel full, and you're seeing results right away. Cost. So in our office, we charge an initial consult fee of $125. That big lab panel that I mentioned is $347. And then the medication cost is significant. That's where the big cost is. It's $1,200. So $1,200 for 12 weeks is what we're kind of telling people for the medication cost. Okay, does semaglutide always work? Well, of course not, because if people aren't like making the lifestyle changes they need to make, if the doses aren't adjusted appropriately, if they're not a good, patient, like, yeah, if they don't tolerate the medication, and if their expectations aren't realistic, they're not going to lose weight. And so this is also where Kim Sandman as a health coach can really come in and really support these patients from a lifestyle perspective to coach them into doing all the things that it takes to lose weight.
One of the things that I think is helpful is to work with patients while they're taking the semaglutide, so that while they're in the process and seeing success of weight loss and maintaining muscle and those kinds of things, they can start to develop new habits and learn how to balance their diet in a healthy way, so that once they come off, then they can really continue to see the benefits that they've gained. And then also have a lifestyle that's not going to put them back in a situation, not only for weight gain, but also put them back in a situation where they're going back into metabolic dysfunction.
Mm-hmm. Yeah, one of the gals in our office who had an excellent response to semaglutide, I think she lost 40 pounds. So she's weaning down. We're trying to get her off of semaglutide, and she is really, really worried that her cravings will come back and that she'll gain this weight back. And she really does look fantastic. And I think that's where Kim and other health coaches can come in alongside these folks and say, don't be scared to come off of semaglutide. We can get you off, and we can, make some changes in your whatever needs to be done to help you maintain this wonderful weight loss. And then I added this slide too. This is just from Hippocrates. He's like an old smart guy, right? The greatest medicine of all is teaching people how not to need it. So yeah, that's like a huge success if we can teach patients how not to need the semaglutide and maintain a healthy weight. Yeah, that's it.
Thank you, Becky.
Yeah.
I had just a couple things that I wanted to mention. So Becky mentioned fatty liver disease, and I can't put my finger on exactly the article at the moment, but there have been even news articles talking about how the leading cause of liver transplants are becoming like non-alcoholic fatty liver disease. And so, just like obesity, diabetes, it's cardiovascular disease, it's all a part of this metabolic syndrome, all of that. So even, just the whole liver transplant scenario is becoming more of a deal because of fatty liver and diabetes and whatnot. And as Becky mentioned, one of the nice things about our InBody is that it does measure visceral fat, and it helps to calculate your basal metabolic rate from, your muscle mass and things like that, because we know how many calories in a day it takes to feed your muscles. So there's a lot of information on there. And, there are ads on TV, everybody's doing it kind of thing. But I think there is there is a difference, like Becky said, in terms of doing it really responsibly. And, it's this kind of thing, I think, that all of a sudden you find the FDA coming down on everybody because it becomes like this fad or this big money-making thing where all of a sudden everybody's doing it. And, it's crazy the stories that we hear, like, people that don't know how to give their injections, but the stuff gets mailed to their house and they don't know how to do it. They're not being monitored. I know we get a pretty extensive lab panel. And I mean, I think really if you were even going through insurance, we get about $1,600 worth of labs for that 347 or whatever the number that Becky said. So, I mean, it can be a hardship for people. I mean, as far as, paying cash or whatnot, but it sort of depends. Like if you don't have insurance or you haven't met your deductibles or your insurance isn't going to cover some of the labs, they're actually pretty affordable because you're also not getting them all the time. But it's a very broad spectrum of labs that we get because we have done some secret shopping at other practices, and they'll say, well, you get 4 labs for $120, so they're $30 a piece for these 4 labs. But I can't imagine if somebody needs their thyroid optimized, that alone is 4 different labs. So I'm not sure what exactly these people are monitoring. So, that's important. And then we also look at hormones. So for example, as Becky said, testosterone is really important for maintaining muscle mass. And people say that muscle is the currency of aging. Very important metabolically, cardiovascular health, musculoskeletal health, all of that. But also estrogen. So I think estrogen, sometimes particularly in men, gets kind of a bad rap, but estrogen is known as a visceral fat shredder. And if you look at the estrogen levels that we like to run our men and women, usually around 80 to 120, it's about the same for men and women. So it's a little bit of a fallacy to say that estrogen is a female hormone and testosterone is a male hormone, because that's not really true. The levels of testosterone in men and women are different, but men and women need both for whole body health, brain protection, bone protection, heart protection. Almost every cell in your body has estrogen and testosterone receptors. So it's very important for men and women. And then one other thought is that there are people that recommend doing the semaglutide if you are pre-diabetic for 6 months to rest your beta cells. So the beta cells are the cells in your liver that produce insulin. So there is this concept, and Becky touched on it, saying that, you know, there is the opportunity to reverse diabetes, reverse being a pre-diabetic. And, you know, one of the ways to potentially do that is going to be through the use of semaglutide to allow those insulin producing cells to kind of rest, if you will. And I think almost everybody on this call is a health coach or has experience in that area. So I think this is a really important, like Kim said, value add that you can bring to people that are successfully losing weight, because as Becky mentioned also, the time to breed more success is when you're having success. And I think when you're starving yourself and exercising and you're not losing weight and it's all kind of an uphill battle, I mean, now is the time to help people make these changes, whether it's activity, mental health, nutrition, all of that. And people don't know how to eat, and people don't know how to maintain the success. So this is where, like, basically each and every one of you can be incredibly supportive to these patients that are having this great success. Right.
Yeah, I like that. Success breeds success. Like patients, they get so excited to come in and get on the scale again. Yeah, and even Tanya, she'll screenshot her scale each week and send to me, because I'm like, how was your week? You know, how much did you lose? And how's your muscle? And all that. So that's fun. And one thing I didn't mention is for patients who are doing in-office injections, we give them a second injection of methylated B12, which is good for energy. And it bypasses the gut when you give it as an injection. And it can be really helpful for if they're struggling with any kind of fatigue issues. So I mean, there's some offices that do B12 injections for weight loss. So it's another value add that we can do.
Right now, I'm working with one of Becky's patients, and we were on the phone last week, and she had weighed herself at home, and it didn't look like the scale had budged. And she said that going into the office and seeing the results of the in-body scan, where she had actually gained muscle, that it was really encouraging for her. And she said, in the past, if I would have, you know, been working hard to lose weight and I got on the scale and I didn't see any change in my weight, I would have been really discouraged. But seeing that me going to the gym and working out and doing semaglutide, my muscle actually improved. And she said that was really motivating for me to keep going and to start making some more diet changes and to see what else can I do.
Right. Versus give up, right? Like,
Right.
Yeah.
Yeah. Throw in the towel.
Yeah.
So do we have questions from the rest of the gang? Anything or any experiences that you guys are seeing out in the trenches with some of these patients?
I guess I have a question about, you know, you mentioned part of the mechanism that slows the gastric emptying. Obviously, you're assessing every week for things like nausea, constipation, diarrhea. Are you seeing any kind of worsening GI issues rising from like stomach acid issues? You know, more than just nausea, I guess,
Yeah.
things that would be concerning for you for greater, you know, gut biome imbalance
Right.
issues.
A little bit of reflux. I have had that. Patients will say they have reflux, and so I recommend decreasing the dose when that happens. And then, so if anyone's kind of struggling with constipation coming into this, they have to be very proactive. One of our front desk gals had bad constipation when she first started, and she thought she was gonna have to quit. And so I just wrote down a list. I'm like, you go to the store and you get prunes and magnesium citrate and probiotics and fiber. And so she had a good success after she was suffering for a few days, but she thought she'd have to stop. And she's like, I don't think I can continue. This is so uncomfortable. So I asked her, I said, well, what made the most difference of all those things I wrote down? What made the most difference? And she said the prunes and the magnesium citrate.
Mag citrate, I'll do it every time.
Yeah, so it's pretty cheap. I told her to get it at Costco. Like that's a pretty inexpensive supplement, and it does work. Mm-hmm.
Well, and I don't know my magnesium as well as I should. Some of it doesn't absorb as well, but it's kind of like who's not lacking in magnesium. I think it's a really common supplement that we recommend to patients that maybe many of you do. And also sun fiber, you can get it on Amazon. It's a fiber and prebiotic, and it's really nice because it doesn't tend to gum up your stuff. Usually if you're putting fiber in something, it makes it kind of thick and gooey. And this is, you could put it in your coffee, and I don't know that you would notice it. It's completely flavorless. It doesn't gum things up, and it is a prebiotic, so it's going to help to support your probiotics in your gut biome. So that's potentially helpful. And then the other thing too, I think that, a lot of patients are on acid lowering medications, which are really bad downstream for your health in general, because your stomach is acidic for a reason. It needs to break down your food into its fundamental molecules and amino acids and sugars to be absorbed properly and used properly in the body. And it also kills bacteria. So there are a number of reasons, it makes sense why your body is has a high acid content, but using digestive enzymes can be really helpful too, as opposed to going, oh, I have reflux, I'm going to start an acid, I'm going to start taking, Tums or omeprazole or something like that. So there are more natural ways to improve the acidity in your stomach. So I think there are other very healthy ways to approach improving your gut during this process as well.
Yeah, gut health is key, right? It affects the whole body's functioning and mental health in particular. So if you can fix the gut, and the gut can start making good neurotransmitters, those make people feel happier.
Yeah, I guess my other question, or I guess I would kind of expect maybe this is something you're finding as another positive, is probably someone comes in, they want to lose weight or they want to get their blood sugar in check. But are you finding people at the end of it, after it's probably helping, again, these insulin levels and the insulin resistance? Are you finding people that are like, wow, that really helps this other chronic disease, that are this other like autoimmune, I didn't expect this positive side effect? Are you seeing a lot of?
Yeah, so funny you said that. So I have my very first patient that I put on tirzepatide, which is semaglutide plus another GIP, which is a I forget exactly. Anyway, it's another peptide. It's a dual action. Anyway, she has significant autoimmune disease like scleroderma, Raynaud's, whatever. So she wanted to lose not a lot of weight, like 12 pounds. She wanted to lose like 12 pounds. And she wanted the tirzepatide versus semaglutide because she had read that it was a little bit better. It is better for some. And she had really great results with the weight loss, like on very low doses. And the secondary benefit, she said, I feel just in general, like my face is as inflamed. I don't feel like I'm as swollen in my hands. And she's like, I feel like I don't have an autoimmune disorder anymore. And I was like, really? I mean, that's amazing. Like unexpected, like a huge secondary benefit. Yeah, that was fun.
And one thing I would add to that is sugar in general is very inflammatory. And so if your body's not processing sugars properly, that's an issue. But they are finding that it can help with your kidney function. It helps with your cardiovascular function. And a lot of this is by decreasing inflammation in general. But another huge benefit is actually brain health. So it helps to improve, the dendrites. So if you have the main cell body of your neuron, and the axons feed, signals out from the cell, and the dendrites are the branches that receive signals. So it improves and increases the sprouting of the dendrites, the neuronal dendrites, and it improves the plasticity in the brain so that you get more and improved neuronal connections. And it regulates or modulates the microglia, which are, they are kind of upregulated when you have inflammation, because they go and eat up and get rid of old dead cells and all of that. But if you have a lot of them, it means you have a lot of brain inflammation. So just from an organ health standpoint, there are studies showing cardiovascular risk is decreased, improved kidney function, and decreased brain inflammation. So, and just in talking about the side benefits of it, there are a lot of them, and a lot of it just stems from, better glucose regulation. One of the things that a speaker that Becky and I both heard was, he's a peptide expert, and he talked about patients that feel better. So this might be something to be alert to, that patients who feel better when they're on a keto diet, their brain, if they say their brain fog is better, that's a bad sign, meaning it's good that they found something that makes them feel better, but that's an indicator that they're not properly using glucose for energy. They're needing the ketones, which is, sort of a downstream from glucose metabolism. They're not even using glucose to power their brains anymore. Because they're not using it properly, they're needing these ketones, which, gets fed from doing a ketogenic diet. So for those people, if they haven't had their labs checked recently, you really need to have them look at their fasting insulin, their fasting glucose levels, and their hemoglobin A1Cs to check to see, where their sugar situation is.
Yeah, the labs are essential, and it's fun to do a repeat lab panel. You don't have to repeat everything, but some of the markers that were, not optimal, to repeat those at 12 weeks. And we've cut insulin levels in half with 12 weeks on semaglutide. And that's just data, right? That's just science. And patients are losing weight, feeling better. According to Tanya, they're smarter because their neurons are working better.
Other people seem to be smarter.
Is Andy smarter?
Hard to say. Early. Andy's my husband. So other questions?
Yeah, the more I learn about it and the more I work with it, I'm getting more impressed. And I'm also seeing patients coming from other offices where maybe they weren't quite as detailed in their intake and lab interpretation. And patients are like, oh, I tried it, I didn't like it, I had all these side effects. I'm like, okay, if you want to try it again and do it differently, I feel really good about giving it another shot.
Great. Thank you, Becky.
You're welcome.
I don't really have a question, but I have a couple of comments. I really, really appreciate this presentation because I have been hesitant to share with anyone in my circle that I started it about 12 weeks ago and working with it, obviously another practice, because I didn't realize you all were doing this, but thankfully my nurse practitioner recommended it because of my suspicious, weirdly elevated levels of triglycerides and A1C, but not to the point of that anybody was concerned about. And I kept, I've been dealing with or trying to get to the bottom of essentially metabolic syndrome for me, because I have weird fluctuations in my glucose levels, and I get fuzzy and kind of feel like crashing, but my levels aren't so low that anybody's worried about it. So it's been weird. So she suggested that I start this, and it's been 12 weeks and I've lost 12 pounds. And we started really, really low dose, and I'm
Good.
now at my maintenance dose. And I don't, just this week, like I just started the maintenance dose, and they do add the B12 to it. So I appreciate getting all this knowledge from you all, because I was really hesitant to do it because I was scared of it. And because it feels like this, oh, it's a magic pill and it's going to solve all the problems. But I haven't had any follow-up labs, which I'll be excited to do that, because I'll ask her about that next time to see where my A1C is and, where all these levels are now. But it really has made a difference in my motivation, because I've been trying it hit me about 5 years ago when I hit, well, maybe about 49, and I couldn't, like, I'm a nutritionist. I eat grain-free, like I eat super clean, everything's organic, all of those things. And I just kept gaining and gaining and gaining. So obviously there's hormone fluctuations and there's all these things going on. We're diving into hormones now because she didn't do a full hormone panel, and she's working with the pellets, the bioidentical, which I think you all do something along those lines. So I'm really excited to add that, because I think that will, when I'm done with the semaglutide, maybe help manage any future weight gain, because my hormones will finally be regulated.
Yeah. Pellets are great. We love pellets.
Okay, good. Good. I'm glad to hear that too. I've been so nervous about all of this because I just don't know enough about it.
Something to just know about proper hormone balancing is that, again, estrogen is a visceral fat shredder for both women and men. But if your body needs estrogen for many things. Like I mentioned, it's on almost every cell in your body, bone, brain, heart. And if your estrogen levels are low, the other cell in your body that makes estrogen are fat cells. So if you think about most women and then men who get that belly fat, there's not much to pinch on the outside, but there's the beer belly on the inside. So your body knows how to compensate. So as our estrogen levels drop, your body will make more fat to make more estrogen. And then what do? Well, we starve ourselves and exercise. And then your body says, okay, well, I thought I had this thing handled, but now I'm starving. And then your thyroid will go, oh, I'll help. I'll slow down our metabolism. So then it makes something called reverse T3, which is a way, it's like anti-thyroid. It blocks the thyroid receptors so that it slows your metabolism down. So all these things that we're doing on the outside are counterproductive to what your body is trying to do homeostatically, right? It's trying to reach a balance, it's trying to reach homeostasis. And so just another example of why estrogen is so important for men and women. So if you think about dementia, for example, women tend to get dementia earlier and more often than men. So part of that is because of estrogen loss. So when women go through menopause, they lose their estrogen, like you really don't have any estrogen. Men make estrogen as a breakdown product, a metabolite of their testosterone. So even if a man's testosterone levels are low, they're still making estrogen. Whereas women, when we go through menopause, we don't have the estrogen anymore. So they did these cognitive studies on women a month before they had an oophorectomy or a total hysterectomy where their ovaries were removed. And they did that same cognitive measure every week for 6 months after they had their ovaries removed. It only took 30 days to see a measurable cognitive decline in these women who had their ovaries removed. So if you want to talk about brain protection, it's really important for both men and women to have estrogen on board. So again, for men, that means you need your testosterone levels up so that you're making the estrogen that you need.
Mhm. Yeah, I've learned that one conference, some advanced hormone training, basically a kind of a phrase that estrogen is memory,
Mm.
right? So estrogen is memory. So yeah, as we get older, more forgetful, or lots of
And
things, but
and then I will probably in the next 3 or 4 months be giving a little hormone talk. So stay tuned.
yeah.
I thought it was very informative. Thank you, Becky. I like your approach to it. It seems a lot less scary the way you do it than what I've been reading about with how other people go about it. So I like a cautious, that conservative approach instead of just, the generic dosage. So thank you.
Right.
Good. So thank you, everyone. Thanks for joining us. Thanks for all the great questions. And thank you, Becky, for putting this together for us.
Thank you. Thanks,
Thank
everybody.
you.
Thanks.
Thank you.
All right. See you next time.
Thank you.
Bye.